Christmas party was sort of enjoyed by all. We looked forward to the opening of the Koch Center, and on December 10th, it was we were present for the dedication, and we actually planned to open the dental clinic in March. And actually went to celebrate the Lunar New Year in Washington, D.C. with my daughter, with the lanterns at the Kennedy Center. So, you know, all was seemingly right with the world. I actually got to attend my APS meeting in February in Chicago. But then the coronavirus hit. And we had some hard times in between. I got these graphs from the New York Times the other day. You see we've had two peaks so far. And it's interesting because we're on a downhill slope of the second peak, but it's still basically as high as the first peak was. On March 1st of 2020, the first case of COVID was detected in New York City. March 2nd, there were 88 confirmed cases in Washington State and 6 confirmed deaths, which were the first in the country at the Washington State Nursing Home. On March 16th, New York State Dental Society issues a recommendation that dental offices provide only emergency care to patients. And on that same day, we at MSK Dental canceled all in-person didactic meetings. 2 days later, on the 18th, the dental service began its weekly didactic teleconferencing, which continues to today. 4 days later, Governor Cuomo issues an executive order changing the recommendation that dental offices respond to emergency service to a statewide mandate. And again, during the mandate, we got very savvy with Zoom and other forms of telecommunication. The mandate was supposed to last till mid-May. I think it went actually a little bit longer than that. So during that time, as we've all seen, there was a run on supermarkets. There was a run on, let's see if we can let Debbie Lee into the talk. Run on pharmaceuticals, hand soap, cough medicines, disinfecting wipes, obviously paper goods, even, you know, basic foodstuffs. I mean, the shelves were bare. You felt like you hit the lottery when you found some Clorox products, you know, at the local store. It was definitely confusing to our pets. We started religious services on YouTube. And if there was only one positive of this whole pandemic, was the fact that because of the restricted traffic, the air was cleaner, the streets were cleaner, although they were deserted. And you know, our attire certainly changed. I mean, this sort of reminds me of the Cobra Kai commercial you see on TV. The photo on the left is my leisure outfit, and the photo on the right is my work outfit. So basically the N95 mask under the regular mask. The cafeteria, this is the main dining room in the cafeteria. Single tables with single chairs, and this was like in the middle of the day. MSK arranged for an outdoor R&R lounge for staff members just to be able to congregate outdoors. Of course, this was during the warmer weather. The waiting rooms were empty, basically. I mean, we didn't have problems with patients piling up to come in. Signage was everywhere, constantly reminding us to wear masks, maintain distance. Even the elevators, you know, allowed only 4 people per elevator. We were only using every other room, and 7 was converted to a PPE storage room. And again, at the beginning and even now, we were only using every other room. So only every other room was open, and the doors to all the rooms were closed. Again, signage everywhere on the floors, on the walls, in the lobby, wear a mask. So all of this, we've all lived through, but unfortunately, on February 19th, actually before the pandemic, we lost one of our own. And, it was not due to COVID, but a terrible and tragic accident. And thanks to our OCs, we have this little video. I had the privilege of working with Annette at MSK for the last 30 decades. As many of you know, she was the voice and face of the MSKCC dental service. She was the first person contacted when patients or colleagues called, and usually the first face I saw in the morning. She was on the firing line every day and handled her duties with equanimity and aplomb. She never lost her cool, even under the most trying of circumstances. She always wanted to do what's best for the patient. She knew most patients by name and what their appointments entailed. Very often patients would bypass the session assistant saying, "I'll call Annette later." Annette's tragic passing has left us, her dental service family, stunned. Our dental service is a very close-knit group, and Annette was one of our sisters. We cannot know for certain how long we have or what trials or misfortunes will test us along the way. We cannot know what God's plan is for us. The best thing Annette has left behind for us is her example. We can use each day to show those who are closest to us how much we care about them and treat others with the kindness and respect that we wish for ourselves. As someone once said about Annette, heaven has gained an angel, and sadly we have lost one. Annette was sunshine, joy.
She's missed by me every day.
Wonderful cook, kind, hearted soul. Every day, Annette taught all of us how to be kind, selfless, and generous.
Annette was funny.
Whenever she called me in the office, it always started with Dr. Halpern.
That was dedicated and kind. She was a great person who added so much to every life she touched.
She was very respectful of my time and the time with the patient.
We'll always remember Annette as a very special part of the dental service, that she was a loyal and respected member of our team and will always be remembered by all.
She was loving, she was kind, she was also very generous, and she would often cook meals for her peers.
She made the most delicious lumpia and really gave them out freely.
It takes a minute to find a special person, an hour to appreciate them, and a day to love them, but it takes an entire lifetime to forget them.
Annette fits all those beautiful descriptions and more. She was dental's unique sassy gem. She's continuously missed by all every day. May her beautiful, angelic, kind, God-fearing soul continue to rest in peace. We miss you, Annette.
So on that somber note, we dedicate this meeting to Annette's memory. And I'd like to introduce our first two speakers. As our tradition has it, we invite a younger alum and a more seasoned alum. This year, James Iovino will start off the program, class of 15, and Dr. Randazzo will follow up, class of 1989.
Can you please?
Okay. So, take it away, Dr. Dr. Iovino.
All right, great. Thank you, Dr. Huryn. Let me just pull up the presentation here. All right, first, good afternoon, everyone, and just want to thank everyone at the dental service for inviting me here to speak, and really just want to talk a little bit about my experience in terms of caring for the dental cancer patient from my fellowship now to my current role in private practice. First, just a little bit about myself. I grew up in Southampton, New York, and after completing my education and dental training, made my way back home, where currently I work alongside my father in private practice. I'm a periodontist. My father is an oral surgeon, and just want to share a little bit about my journey and how my training at Memorial Sloan Kettering really has shaped how I practice and care for the community here on the East End of Long Island. Dentistry was something I was always around. I grew up observing my father and had an interest in the profession. And after dabbling in history and liberal arts during college and afterwards, I decided that it was my calling. And in 2009, packed my bags to head to DC to go to Howard University. After dental school, I returned to New York and for a general practice residency at New York Presbyterian Cornell. And it was during that time where I was first able to spend time at the dental service during an off-service rotation. Following that year, I applied and joined the dental service as a fellow in 2014 and 2015. A little bit more in terms of my background. After that, I did do my periodontics training at Stony Brook University. As I mentioned, I currently practice out on the East End of Long Island with my father. Our primary practice is in Southampton, New York, but we also have an office on the first town of Norfolk, which is Accabock. And I'll have a few photos kind of throughout the presentation, just of some areas here on the East End. For the bottom photos, those are potato plants, if anyone's curious for what crop that is. So as we know, dental oncology involves working in coordination with the oncology team to enhance the patient's quality of life before and during and after treatment. It was during my fellowship that I really gained familiarity with the challenges and the satisfaction that caring for this patient population can really provide, and also invaluable insight in terms of how to best approach their dental management. And since then, and throughout all aspects of my practice and career, I've tried to apply what I've learned to the care that I provide. I've shared these lessons both in lectures and conversations with my colleagues during my residency at Stony Brook, and also have with my local dental providers in my community. Just this week, I've tried to have care for these patients be a part of my practice, and just looking over my schedule the last really week and a half, there's been a number of individuals who have fit this criteria. Just a few examples are an 80-year-old male who had a history of head and neck radiation, and we went forward where several of his teeth were treated with root canal and then decoronated to try to reduce any risks associated with surgery. A 75-year-old female with a history of lymphoma who recently, not that long ago, had a stem cell transplant and now was in need for several extractions. Additionally, a couple of an 86 and 76-year-old male with multiple myeloma, one individual who was referred by his oncologist for evaluation of a draining fistula on a lingual exostosis, and another one whose oncologist wanted us to evaluate jaw pain and rule out any presence of RONJ. So it's the majority of my patients, both in general and also specific in cancer patients, do come from a referring dentist, but I've tried to work with the physicians and oncologists in my community to try to provide and meet the dental needs and care of their patients as well. And throughout all of this, I've really relied on the knowledge that I obtained and learned at Memorial Sloan Kettering to provide that. So I just want to, for main presentation, just share a few cases that are representative of some of the types of patients that I've seen and some of the treatment that I have presided over the course of the last year or so. This is actually a photo just of Dune Beach in Southampton. So while I was at Memorial Sloan Kettering, I spent a fair amount of time in the basement helping out with the dental dosimetric contouring. And as we know, this really enables us to get a sense of what the maxillary and mandibular regions, in terms of how much radiation they might have received. You know, it's not a precise dose, it's more the planned dose that was prescribed leading up to their treatment, but it, you know, does assist us in terms of planning post-radiation treatment by assessing the relative risk that these individuals may face following any type of dental surgical procedure, namely osteonecrosis, and it enables myself as a practitioner to have more informed decisions with my patients and to try to, as best as we can, avoid complications when possible. So it's been an invaluable tool for me dating back to my fellowship, and one that I still rely on to this day. And just a couple of recent patients that I've seen that I've applied this treatment to. One is a 73-year-old male who was referred by his dentist, who unfortunately had a symptomatic tooth number 31. This individual is really the ideal head and neck radiation cancer patient. He was maintaining immaculate oral hygiene, made the dietary changes necessary, and unfortunately just fractured this tooth here. It was symptomatic, it did probe, and it had a J-shaped lesion that was concerning for extraction. So with the assistance of Dr. Huryn and the fellows at Memorial, I was able to obtain his radiation records. And with that, could see that the radiation that tooth number 31 likely received, and discuss with the patient the potential complications associated with any surgery. But since it was below the threshold that we typically would start having more serious concerns about healing, we made the decision to move forward with the extraction, and everything healed uneventfully. The site has displayed complete epithelialization with no erythema, edema, or any exposed bone. So here's an example of where it really helped me in my own practice, you know, talk and plan treatment with the patient. As I mentioned, that individual was doing incredibly well following treatment, but I think, as we all know, we fortunately have patients who post-radiation do have a tendency to have a high caries index. And here was another individual who was seen first back in the dental service here in 2002 for squamous cell of this left base of tongue, underwent treatment at Memorial Sloan Kettering for that. And he was referred by his dentist for evaluation of multiple carious teeth, is what we can see in the pan on the top. What really complicated this gentleman's care is that he's also being currently treated for dementia and Parkinson's disease, which really limits his dexterity. So maintenance has been really challenging for him. But again, with the help of Memorial, I was able to obtain his contouring values to talk with him and his wife in terms of what the relative risk would be following any type of surgical procedure. And we've managed to move forward with the extraction of several teeth, namely numbers 4 and some of the anterior incisors, without any complications. I did talk to him and his wife and his dentist about the importance of dietary and oral hygiene changes, and really have encouraged non-surgical treatment, namely root canals and restorations. However, you know, just because of the challenges with his other medical conditions, there has been progression. We're currently in the process of really getting him ready to extract likely teeth number 20 and 21. But contouring has been an invaluable tool in helping me talk and plan treatment for these patients. And we really, what the service that Memorial provides in terms of the specific information they give is incredibly helpful. Here are just a couple other contouring, or I should say radiation reports, which aren't nearly as helpful or detailed as what the dental service there can provide. Next patient I just want to share is it was a 76-year-old male who presented after he's being referred by a dentist. He had a lower right lesion that following extraction of tooth number 30 performed by a general dentist earlier in the winter. He had discomfort following that. He sought a second opinion with another general dentist who then referred him. Of note, the patient had a history of multiple myeloma dating back to 2015, for which he was treated with anti-resorptive therapy, IV Zometa, and then more recently Xgeva. His medical history really was pretty unremarkable beyond that. And when he presented clinically, site number 30 displayed a granulomatous appearance with associated erythema and edema. No bone was visible, but I was able to probe really the entire length of the socket, 10+ millimeters. And, at that time he had no separation or real tenderness, no paresthesia, though at certain points later on, he would have some discomfort. His hygiene wasn't the best. And as we can see here on the panoramic x-ray, he had extensive dental work. Site number 30 displayed a mixed radiolucent radiopaque lesion that extended laterally and inferiorly. Multiple endodontically treated teeth. He had a couple of teeth had periapical radiolucencies, and on a CBCT that was taken, we can kind of better appreciate the lesion and its progression towards the alveolar nerve. So given the patient's history and his persistent discomfort and clinical and radiographic presentation, the diagnosis of RONJ was assigned. At this time, I took time to talk to the patient extensively, kind of the pathophysiology behind this process, the different treatment options, and how things could play out. The decision was made in consultation with his physician that he move forward with the prescription of pentoxifylline, vitamin E, along with Peridex and amoxicillin. Much like the other patients, I did encourage him the importance of regular dental visits for non-surgical dental treatment and really maintaining good oral hygiene. Also offered him referrals for other providers that may have gone in and provided more of a surgical debridement, at which time he deferred. So just a little bit of background, as we know that pentoxifylline and vitamin E is shown to have a benefit for patients that are suffering from medication-related osteonecrosis, as a case series published by the dental service a few years ago showed. And with pentoxifylline, it's been believed to kind of help in these patients by improving peripheral blood flow, enhancing tissue oxygenation, and decreasing inflammation and fibrosis. The vitamin E similarly helps reduce the effects of some of the oxygen radicals and reduces inflammation and fibrosis as well. It'll be interesting to see, there's currently an undergoing randomized clinical trial that started in 2018. That'll hopefully provide a little more insight in terms of exactly how much this treatment could be a part of caring for these patients. But from seeing in my time at Memorial and also talking to my attendings, it's something I've adopted in my practice and I think has helped some people. So with this gentleman, there was progression of the lesion over the course of the first 3 months. He still really wasn't reporting any significant symptoms and no paresthesia. To the tooth distal to it did display some mobility. At the 6-month mark, I did update the CBCT, and again, we can see progression, and there is extension towards the inferior alveolar nerve. However, just before this, he had exfoliated a piece of necrotic bone, and the area started to feel better. And just a few weeks ago, I saw him for a follow-up appointment, and the site has really responded well and is improving. That granulomatous tissue really has been reduced. Still, as I never was able to visualize any bone, but now throughout the length of where the extraction socket is, I can't probe more than a millimeter or two deep. So there was an improvement between the initial and currently, and the impact that that medication may have, might have hopefully will prevent any further progression, and is something that I've relied on. Just kind of on that topic there, just wanted to share one other patient that isn't necessarily a cancer patient, but one that I've seen some success with that combination of treatment. And this was a 82-year-old female who presented for extraction of a fractured tooth number 4, really an unremarkable medical history, other than osteoporosis, where she was receiving Prolia. Number 4, and I apologize for the poor film, displayed really kind of circumferential erythema and edema, really a kind of an ugly granulomatous appearance as well. That was sensitive upon palpation and was separating. Discuss with her the possible complications associated with medication-related osteonecrosis of the jaw, and we move forward with extraction given its symptomatic nature. At the time the tooth was removed and the site was debrided, the bone really had an appearance of necrosis at that time, and really discussed with the patient that the process might have already been going on. Followed her post-operatively. This site never displayed complete healing, and was still able to probe the bone with separation noted. Not long after, she presented with an interproximal abscess between number 6 and 7 with multiple draining fistulas. And at that time, I non-surgically debrided the site and also started her on the regimen of pentoxifylline and vitamin E. Here we could see on the CBCT that was taken a couple of years ago, there, pretty extensive breakdown of the bone into the sinus, and on the axial view, you can see it tracking anteriorly and where it came out between 6 and 7. I reviewed with her different treatment options, and she deferred any real more extensive debridement and wanted to stay on just the medication with the understandings of how things could progress. And we followed her, and really she's healed quite nicely. This is just at the end of last year, where there's almost complete bony fill at the extraction site, and even the part where it extends anteriorly. And I don't have an initial photo of her. This is how the site is now, with no erythema, edema, completely epithelialized. And just a comparison between the two CBCTs. So with all these patients, the head and neck radiation patient and multiple myeloma, I've really relied on the lessons that I learned at Memorial to care for them, and more importantly, to share what I've learned with the dentists in my community. And really am incredibly thankful for the opportunity that I had going back, I guess 5 years now, to be a part of the dental service, and want to thank Dr. Huryn and everyone for inviting me to speak today. And thank you.
All right, good job, James. If you would stop sharing your screen so we can get Dr. Randazzo onboarded, and then we'll have questions after both presentations. Okay. Okay, there we go.
Okay, I was forced into this, so I'll do the best I can. And if there's any questions at the end, please, I want to direct those to Dr. Huryn. But anyway, Dr. Yam, as we were trying to put this together, she wanted something, I guess our point of view as to the experience we've all been through for this year. So, when I see patients in the office, I say to them, did you ever in your lifetime think you'd be living through a pandemic? I know we've had warnings with Ebola and the AIDS epidemic and those kind of things. And, you know, in my opinion, things like this only happen in like third world countries, and because we've always been like separated by two oceans. But because of globalization and things like that, you know, it's really hard to control these types of events. So again, this is a very unusual way of presenting, you know, an alumni event. But during my time, during this COVID crisis, I I would do walks after we've had our Zoom meetings with our fellows and other things. In my community, I would go around and walk around the community, and I was able to capture some pretty interesting flowers and arrangements. And this was during the spring of 2020, about a year ago. And these were actually some flowers that were around my house and in my garden. And these were just some wildflowers that I picked, that I noticed along the way. So today what we're going to try to talk a little bit about is not religion, although we've seen the Pope and made some comments about some recent events, nor political, even though this fine man here is under the gun. And but we're going to talk about science. And if anyone, I don't know if anyone's familiar with this face, this is kind of an old version of Watson, who was the co-discoverer of the structure of the DNA molecule. And I have this person on the far left highlighted because it's kind of sad, because she wasn't included on the Nobel Prize in 1962 because she had died from ovarian cancer at the age of 37, but she was very instrumental in the discovery, and she wasn't given any credit at all. So I was just very moved by that, and I wanted to share that with everyone. Getting back to this crisis that we're in now, I don't know if any of you were aware that in 1948, I don't want to show this little video here because I might not be able to get us back on, but it was very interesting. I was watching this noir show on Turner Classic Movies, and it was called The Killer That Stalked New York. And you can actually see these lines. So you wonder, what did this represent here? Well, anyway, in 1947, in March of 1947, which is probably, you know, if you think about it, in March is when the highlight of COVID was here, that this businessman, I think his name was Lemure, he actually traveled from New York City, from Mexico City to New York City. And when he came to New York City, he actually lived in Maine. He came with an illness. And so, you know, during that course of time, he was taking headache medications, had a really bad headache, and he was sick. So when he got to New York, he and his wife were sightseeing, and he was saying to us, "Oh, I'm going to get better. I'm going to get better." He didn't, however, get better. He actually collapsed in his hotel. He was taken to Bellevue, and they couldn't figure out quite what was wrong, but they noticed a rash on his body. And so they switched him over to Willard Pollard Hospital for Communicable Diseases. And even there was difficult to determine a diagnosis because on his arm, he did have the scar from the smallpox vaccine. He, however, later on, it was noted that he, in fact, did have smallpox. And this is just a representation of how smallpox, you know, when you have, you know, full-blown infections, you get these growths on your face that are full with pus, and they eventually erupt. You die because it affects your immune system. And they just recently found out how the true mechanism of action, which it apparently the virus creates a protein which blocks interferon. So the immunity gets so suppressed that these people succumb to their disease from that. But if the persons who did survive, they actually could sometimes go blind, and they would have this wretched scarring on their body. This is actually a line going for in 1947 at Morrisania Hospital in the Bronx, in line to get the vaccine. And these are some other pictures. So this little quote on the top was actually a headline in the newspaper and also on the radio. And this was actually sent out by, at the time, the commissioner of health in New York City was a person named Israel Weinstein. So he said, be sure, be safe, get vaccinated. Within 3 weeks of the discovery of the outbreak, the U.S. Public Health Service plus New York health officials procured the smallpox vaccine. They vaccinated about 6 million people, children and adults. And because of this rapid response, there was just a limited outbreak to 12 people, 10 recovered and 2 had died. And this is actually an example of, I don't know in relation to where you live in Queens, Dr. Huryn, but I'm sure you've heard of St. Joan of Arc Parochial School. So this is actually the kids getting vaccinated at the time in 1947. And by the way, this is a familiar face to the right. He was actually born in Brooklyn, and he actually lived through this outbreak. And he was 6 years old when he was vaccinated. And I guess, what goes around comes around, and this, we can get rid of this. And I will go over some of the measures we need to take. As a matter of fact, this 2020 was the 80th year or the 40th? I can't remember now, but when smallpox has officially been eradicated in the world. And I think this is the 40th anniversary of that. And smallpox had claimed the lives of over 60 million people when it was in its full course of action. So what do we need to do to protect ourselves and those around us from the coronavirus? Should we eat some mushrooms and hallucinate and then see some gnarled looking roots? Or should we, this is actually what was recommended by the CDC, and we truly abide by this, that wear a mask, avoid, et cetera, et cetera. You can all see this, we're all abiding by this. But this is actually me getting the vaccine. I wanted them to show me actually getting punctured, but they missed that. This is my wife, the poor thing. She's getting a vaccine. My wife is a neonatal physician. So the most important things are to get the vaccine and do all those other things you need to do. I actually took a photo of this, and I want to thank all of us, because we're all first responders and essential workers in trying to control this particular disease. So a little bit about myself, my autobiography, and this is me peeking into the future. So, I was the youngest of 4, only one to go to college, professional school. I've been local for most of my life. I went to Catholic school. In high school, I was voted most likely to succeed, obviously because I'm charming. And just kidding. I studied marine science and biology. Actually, I went to a college in Southampton called Southampton College, which is at the time was part of Long Island University. Played soccer 4 years, and then I taught for a year, and then I went to dental school at NYU and graduated in 1985. But I was fortunate that in my junior year, they had an internship at Memorial Sloan Kettering. And so I said, wow, well, let me go see what that would be like. So I wound up coming here, and the room where we had the Panorex now, there used to be a computer in there, and I had worked with Dr. Rosenberg at the time, and we did a little project, because at that time there was an AIDS epidemic. It was in the mid 80s at the time. And so we sat down and we said, well, let's come up with a little project that, is there any relationship between opiate use and the effects on the immunity and the T killer cells. So it was quite an interesting project I was able to do. And at that time, I think that's when I got the bug, the MSK bug. And so I finished dental school, did a GPR in Newark. And then I said, I was wondering, how can I get back at MSK CC? Because the program, when I was an intern, it was a 3-year program where you did pros and then you did max face. But, by the time I would be able to apply, the program had changed where it was only like a 1-year program. So they told me, they go, well, if you get a pros certificate and you apply, we'll let you in because of your excitement and enthusiasm about the program. And so I said to myself, I'm going to go out to Wisconsin, because I really didn't like any of the schools. Like at NYU, I didn't really find a good experience. being around. So I went out to Marquette, had a great time there. And then I was wondering, because the year that I applied, two other people from Marquette the year before, sisters, had applied and got in. I'm going, oh man, are they going to accept me here? And also, and I'll show a little bit later, my colleague at the time, Paul Conradi, we both applied, and fortunately, we were both accepted. Yay! So then finished that up. I was hoping that I could have stayed on, but you know, it just wasn't meant to be at that time. So after that, I went into private practice. I taught at NYU in New Jersey. Took my boards the same week. I took my boards in 1994, and that same week I got married. And I'll show you. Did an implant fellowship, and then I received a call from Dr. Huryn in 2012, and I was in practice. In my practice, and I remember distinctly picking up the phone and going, wow, this is great, man. This is my opportunity. I just finished the implant fellowship, and I said, wow, something that I always wanted to do. And I'm finally, like they said in the movie when Al Pacino goes, they called me back. So since then, I've been in private practice, and I've been trying to sell my practice, but because of the current situation, it's been very difficult. I reside in New Jersey. So I just wanted to share my wedding experience with my dear wife, and who I torture all the time. And maybe I look a little stunned here because that was a couple of days before I just finished the boards. And there's some familiar faces here. I had invited Dr. Zlotalo and Dr. Piro to my wedding, and this is Paul Conradi. He was my fellow at Memorial. And this is my good friend, Anthony Wong, who's also a dentist, and he goes on missionary trips. And this is my mom and dad. This is my brother, my sister, my other brother, who unfortunately passed, my nephew. And there I am. Do I look happy there? And this is a little bit more recent, an attending picture. This is when my son, he graduated from college, and this is some family stuff. I like to travel and do things like that. And I try to do triathlons a couple a year. And these are a couple of the buddies that I do with. And I just thought this was a cute picture of my nephew, Kostaiki. And getting back to the time when I was a fellow, this was Miriam Robbins and John Lanzetta. Miriam now, I believe, is the chairman at Winthrop Hospital, chair of dental medicine. And John Lanzetta has a periodontal practice on Madison Avenue. John and I, when we were fellows, we would, and you really can't do this now, we would go in the basement of the resident hall and run from the basement to the roof, and they had access to the roof. So we'd do that at least once, and then we'd come back to clinic afterwards. This is Jennifer. She was one of my She was one of my co-fellows. And I have triple C, not triple D, because Jennifer, I looked at some of her blogs, and, it really does fit that she was caring, compassionate, and competent. And she also was a very good cook. She invited us one time to her apartment, and her husband is an oral surgeon. There I am, like I say to my fellows, take a deep breath, and by the time you finish your fellowship, you can exhale. That's how busy you'll be. This is Paul Conradi, who, in my opinion, is, now he's retired, but Paul is probably one of the best dentists, but of all times. He can do everything. And this is one of the patients that he with Dr. Huryn had restored and had an orbital defect. And these are some of my mentors, Dr. Piro with Mr. Gaffar. I always tell the story, and Dr. Huryn knows. Mr. Gaffar, after we helped him out a little bit, he sent me some pants. He was a retailer in clothes, and he sent me some pants from Pakistan to my house, and none of them fit. So I guess the sizes are a little bit. And there's Dr. Rosenberg, who is also a good, excellent mentor, and Dr. Zlotalo, who we came very close with, and of course, Dr. Huryn. I can't express, my gratitude for their mentorship. And these are some of the people who I currently work with. They're a great bunch of people. And I thank them for all their help, and Dr. Halpern and Tunick, Dr. Greenberg, Dr. Stillo, and Dr. Yam. And these are the fellows who have come and gone on my shift. And I just hope they run their course with joy. And these are our current fellows: Dr. Cronstead, Ken, Jennifer Wynn, Dennis Shem, and Andrew Pishak. And this is a new, she's our dental oncology research fellow, or our dental research fellow. Just a quick view of my private practice. These are some of the patients that I've seen over the years, and try to help them smile, maybe eat a little better. Some of the other things I like to do, most of all, hate to pay bills and taxes, like to do a little bit of this kind of stuff, a little bit of this. This is actually a buddy of mine from high school, did some restorative and a little bit more restorative. Love doing quadrant dentistry. It's a good money maker. Some crown and bridge stuff, some implant stuff. But towards the I really like doing these cases now. A couple of crowns and some partials, and really, I'm kind of geared. I also do some max face, and this is a patient I just recently completed. I'm a little upset I over adjusted this, but I worked in concert with a periodontist, and he was a patient here in MSK, and he had about 5 or 6. Actually, I think Dr. Bowley might have seen him, and I saw a picture of Dr. Bowley earlier. His name is. So I think you might have seen him, Dr. Bowley. So I just finished his case in the office. What about at MSK? Oops, sorry. I kind of took over when Dr. Bowley left some of the ocular patients, which was really a challenge at first, trying to understand on how all of this works. But with Marge, and just doing a little research on my own, I was able to get a decent handle on this kind of stuff. There I am with one of the ocular patients. Wouldn't you like to punch that guy in the nose? Anyway, and we're also called on to do some appliances. I actually worked with Alex Drew and Kyle Gazdak with this case, and this patient had a Ewing sarcoma, and what happened was the first line of treatment is chemoradiation, but the lesion didn't respond and it recurred, and he had to get an orbital exoneration, and couldn't get a second course of regular radiation. He had to have brachytherapy because of, they were afraid that it might damage the brain. But sometimes we're called on to make these types of appliances. This is a patient that we had seen here who developed very severe trismus. I think her MIO was like 7 millimeters. So we were able to, like, with a CBCT and create a model from that, make a silicone prosthesis that she was able to slip in. But what happens with these patients, they get sometimes lost to follow-up. And one of our, Jennifer, Dr. Wynn, actually was able to help her out. She needs some endodontic therapy, but we're trying to get her MIO a little bit greater so that we can get access to these areas. But I always try to think of this as small but important victories, these little things that we do that can help these patients out. You can actually see the appliance in there while we were doing some retraction. This is an unfortunate patient. He was actually referred by a prosthodontist to me, and he is actually the artist who's done the Marlboro Man. And so he had come in, he had a set of dentures made by a prosthodontist, but he lost them. So I'm saying, how the heck are we going to manage this? He still had some residual palate left. So we were able, and I worked with, what's his name? I can't think of his name. He's in Chicago. Really good guy. I'll show, yeah. Well, anyway, with the help of Marge, we were able to make a prosthesis. You can see the residual palate left, and we worked from the inside out. We created some straps, and you can actually see him in the studio wearing his appliance. And the real key here was that in April, we had to finish this thing in order for him to, because he had a show of his work that was going to be displayed. So, and we were eventually going to make some kind an extra oral prosthesis, but this kind of served him well. He could speak, he could eat, and but unfortunately he succumbed to his disease because during this actual time he did have active disease. Currently, I've, which is also another interesting project, and finally got a reasonable handle on it for patients who need fibula reconstructions. This is a patient who we recently worked up. Her disease was so advanced that it actually fractured her mandible. And she was so ill that we couldn't even place implants. But I enjoy planning with the fellows, the treatment plan, and also doing the VSP with them. So do you guys want me to still go on, or are you ready to throw
Keep
me
going.
out?
Keep going.
Go. So today's presentation, I was going to just talk about how about the oncology patient and restorative treatment. I actually read a survey in the JPD about, as a maxillofacial prosthodontist, that in our practices, we're mostly, I think their conclusion was that 65% of the procedures are standard prosthodontic, 25% are max and face, and 9% is about surgical procedures. But of the max face, most of the procedures were obturators, but the next highest was dental oncology. So my point is that through this program, and these are the types of patients we see. Let me go on. And this is also important, that this checklist, that if you go through this checklist, I'm sure that at the end of the fellowship, that they'll be able to comply with all of these. So that's very critical. Getting back to what I was saying is that, you may not do 100 obturators in your private practice, but you will encounter patients who will, and as Dr. Iovino had just showed us, that you form this relationship with with the oncologists in your community, and having this understanding of that these patients do have dental needs, that this is a very important component of your education. Well, anyway, this is our goal for all of our patients, is to have a healthy mouth despite having, xerostomia. And I'm always asking patients some of the strategies that they deal with the xerostomia. Just recently, a patient came in and someone who's real, someone with a very good attitude uses the fluoridated toothpaste that we recommend, and other things, ice chips, aloe vera, coconut oil. All these things are to the benefit. And these are all the things that I've kind of learned, not so much from when I was a fellow here, but recently as I came aboard. And if everyone notices, the Maytag repairman here, by the conscientiousness of these patients, we may turn out to be this, where we'll just go, you're okay. We're very appreciative of your following so we'll just have to wait it out. But I don't think this patient's going to have many problems. However, we do run across these types of patients, and in the literature, this can be a pretty rapid process. It can occur, a full mouth like this in as little as 3 years. And we all know what happens with radiation-related xerostomia, that the two main factors for caries are the lack of production of saliva and the loss of the buffering capacity. So what we teach here, our fellows and our dental oncology resident fellows, is for the patients to follow, reduce your frequency of cariogenic food, and being adequately hydrated is also important, because if there's any residual salivary gland function, I think it's important that that for them to be activated, that we should be hydrated properly. Also key is a high potency fluoride regimen, which we always recommend for our patients. So this patient came in, I was looking at him as I was looking into the aquarium, and I was saying to myself, if I had to do dentistry on him, how could I, do it underwater? Because I think it's a little tough to do cosmetic. Well, anyway, this is a patient who was actually referred in my private practice, and you can see what's going on here. He was actually a fire marshal, and he was exposed to significant particulates and smoke. And his cancer was multifocal, and he had, radiation and chemotherapy. He's been NED for 12 years. And Dr. Shupak, who referred him, wanted to know if there's anything I can do for this guy. I knew up front this was going to be a tough case. Dry mucosa, caries, and he needed a lot of dentistry. So that's why it's not just restorative dentistry, it's comprehensive dentistry. So you can see all the things that are going on here, and working around these. Wasn't a candidate for implants because he had just, and she actually went over the radiation. I didn't have the VSP with him because it was so long ago. So she kind of filled me in as to how much radiation he had. So what we could do here is we prescribe for him endodontic therapy where possible. And so this is kind of like, she gave me this information. And so these are all the things that I was looking, what kind of what abutments, what support, retention, how am I going to do aesthetics, all these other fine things that we're aware of. So I have an endodontist who comes to the office, and he was able to treat this patient. And I envy the endodontist because they finish these things pretty quickly. And it's like, it takes me like hours to do this kind of stuff. So we were planning some radicular attachments, excavate decay, and then, make him some overdentures, fluoride protocol. And since he's been without a prosthesis for such a long time, and his tongue was tethered, I thought that speech and swallowing could help us in the process here. So these are the radicular attachments that I mostly use. But I'm hoping that someday they'll be able to produce one of these that are, because sometimes the 1 pound is a little too strong. We use the black a lot, but I'm hoping that one day they'll be able to produce a 0.5 pound insert. So there's some information. Coronal seal of endodontically treated teeth. We know how important that is because micro leakage can cause failure. Whatever materials that you find comfortable using, I use a combination of composite and amalgam, but resin modified glass ionomers are also useful. But the key is just trying to reduce any contamination as possible. And then I often paint a fluoride varnish on those. But denture adhesives, for someone like this, denture adhesives, we know I've become very fond of the old girl, the denture adhesive. I remember in residency is that, they looked at you with a frown if you were ever gonna, but I think it's a very important adjunct to our care. So these are some of the things that, it enhances retention, stability, and performance. You should spend the time to show them how to apply it and also how to remove it. So we were able to get some endodontic therapy for this patient. I was able to this was just in soft tissue. So I was able to remove that. And, this does take time to do carefully and without getting any kind of contamination. So, took some molds here. I didn't have a lower mold, so I kind of called the technician and he actually showed me. And we also try to use some undercuts where the, undercuts that have been created artificially from the surgery to kind of hold these things in place and whatever the patient can tolerate. And so you can see that, as during the course of treatment, everything healed up and I got a little recession around where we did these kinds of, the sealant and he was good. He would come back for follow-up. We would, the hygienist would see him. We would, make sure he was doing what he had to do. And I was a little worried because I was limited by the room here because sometimes I'll just make a maxillary prosthesis and just have them get used to that. And then, eventually introduce some mandibular prostheses. So these are the kind, we use these as guides, posterior plane, and use the retromolar pad when present, and the tongue position if it's not. And this is kind of a weird tongue position, so it's not your typical tongue position, which is generally the junction of the keratinized, the lateral borders of the keratinized and the non-keratinized, actually where the occlusal plane would be. And it's also in relationship to the tongue position in relation to the retromolar pad. So there he is with the prostheses in place. he's doing fairly well, has some issues with dysphagia. Opening's probably a little bit better. Another interesting patient here. Just tell me when we've exceeded.
Yeah, Dr. Renez, I think it's interesting cases, but we have to let our fellows have a chance as well.
Thank
So,
you.
yeah,
I
if you
just,
could wrap it up. Yep.
okay, that's it. Oh, I'll go to the very end here, and this is actually a case I wanted to just show this. This is one of my favorite patients at MSK. He had multiple myeloma, and he had this failing maxillary bridge. And I actually worked with Alex Drew on this case. And we actually, this is before Alex made an immediate denture. Hygiene wasn't that great, made him a transitional partial. We eventually did a surveyed crown, sealed all the teeth, and made him a nice prosthesis. And he's been very compliant in his home care. And that's it. I don't want to do any more. So I'm just going to go to the very end now. Oh, we're stuck. Oh, we know. Oh. Sorry, folks. Are we done yet? Yes, we're done. So just remember, with advances in cancer treatment, patient survival has increased. So it behooves us to provide comprehensive dental care to enhance quality of life. Thank you. Sorry if I took too long.
No, you're fine. Thank you, Dr. Rendazzo.
You're welcome.
So if we will have, I guess, the fellows start. Oh, I see Miriam Robbins is here. Wonderful.
Oh, Dr. Robbins.
So Dennis, you're starting?
Dr. Pishek will be starting.
Okay.
And I'll be going directly after him.
Very good.
Okay, good afternoon, everyone. I'm Andrew Pishek. I'm one of the Dental Oncology Fellows for this year. And I'm going to talk about a patient who Dr. Rendazzo and myself and Dr. Shim have all treated, who underwent radiation previously here at MSK. So a little bit about myself. I am from a small town in South Alabama, very close to the Gulf Shores beaches. My family has a small farm in Alabama, and we actually have a few from Silver Hill, Alabama to Chicago, Illinois for my dental school at Midwestern University, and I completed my GPR at Loyola University, which is also in Chicago. Fortunately enough, I was there to witness the Cubs win the 2016 World Series and break the curse. I moved to Chicago for this fellowship over the summer, and these pictures in the right side, bottom right side, are of Dr. Stilo, Dr. Shim, and myself on a snow day in Central Park about a month ago. After it snowed about 12 inches or so. And after completing this program, I'll be returning back home to Alabama to work with my dad, who is a private general dentist in Alabama. So for our case today, this is focusing on a 52-year-old female. She has a significant history of substance abuse. She's a current everyday smoker and anxiety. And this anxiety includes dental phobia. She can't really sit still in the chair for very long for dental procedures, and she has had dental procedures done previously, but under sedation. So it's something to keep in mind moving forward. This was her initial radiograph that we obtained in late 2018. She presented to a local oral surgeon's office in 2018 due to right-sided facial paralysis for about 6 months. The oral surgeon obtained a biopsy distal to number 30, and it came back positive for osteosarcoma. If you notice in the mandibular left side, the patient has these focal radiopacities, which is consistent with cemental osseous dysplasia. So the patient was then referred to our head and neck service at MSK early 2019. So she had a fibula free flap reconstruction completed, and 2 endosseous implants were placed by our service, and extraction number 15 was performed due to advanced caries. So this is the picture or a radiograph of her after her surgery. You can see the 2 implants in the fibula, and now number 15 has been removed. So she then presents to radiation service here for post-op radiation a few months after the surgery in March 2019. She received 33 fractions and 66 centigrays total dose of radiation. Unfortunately, she developed bilateral metastatic lung lesions for which she is undergoing chemotherapy. So she started with cisplatin and doxorubicin for the first couple of months in late 2019. And ever since the beginning of 2020, she's been on Doxil. She follows up with our service again, the beginning of 2020, right before the pandemic. She has pain with some of her remaining teeth, but they seem to be restorable. She was PEG dependent, but did take food by mouth. And so at that time, palliative treatment was recommended in restoring these decayed teeth with composite fillings or crown and bridge work. But unfortunately, like I said, she was seen right before the pandemic and it was lost to follow-up. And then she follows up with us again at the beginning of the summer, whenever this current fellow, or the current fellows are at MSK. She complains now of generalized pain for all of her teeth. She's frustrated that she can't eat, she can't chew. Some of her teeth are fracturing, don't know which one. So luckily we have Dr. Singh who completed our contouring for us since she had a radiation completed at MSK. And you can see from the CBCT, this purple or violet area on the right side of the CBCT, this was of the patient's maxilla after her surgery. So this is the planned target volume. And so that maxillary right quadrant was affected, and some of the targeted volume of the radiation did affect the maxillary right side. If we move to the mandible, these mandibular left teeth, these are teeth number 20, 21, and 22, were also within this field of radiation. So we were able to receive the dose volume histogram and see the exact dose prescribed, the max dose on the bottom right, and then the mean dose also in the bottom right corner. And these numbers are then placed in the patient's panoramic radiograph to kind of show us exactly a prescribed dose of the area. So that maxillary right side received quite a bit of radiation, which makes sense because she had the radiation done on her right side. But then these mandibular left teeth number 20, 21, 22, again, I'll go back, were in the field of radiation. And these received quite a bit of high dose radiation. So we weren't comfortable with extracting these teeth just due to the risk of ORN or delayed healing, extraction healing. So we proceeded to have this patient come to the operating room. Our plan was to extract the remaining maxillary teeth, number 5, 6, 8, 9, 12, and 13, and then perform endodontic therapy on the remaining mandibular left teeth, 20, 21, and 22, and seal these teeth coronally. So this is our patient pre-op. So she, as you can see on the right side, this is actually her, we had to pretty much force her to smile because she was very unhappy about her smile. You can see kind of the fractured teeth there. And these shots, you can see a little bit more. She's got change in saliva and lack of saliva, post-RT caries. She's got trismus, wasn't using the Prevident toothpaste. So kind of a sad case, but we really want to take care of her and do a good job and perform the best care we could. So this is a apex locator in the OR. So this is our best friend because it was very cumbersome to take radiographs within the OR and take PAs after each instrumentation. So the apex locator was able to show us, we recorded our working links from the apex locator. So this is again in the OR after everything has been extracted in the maxilla. And you can see these 3 teeth on the lower left side have now been coronally sealed. And this is her immediate post-op radiograph. So you can see now she's completely dentulous in the top, and these 3 teeth on the bottom have been sealed. So what's the plan next? So she comes back to us about 4 months later after this procedure. Now she wants a higher quality of life. So we took care of her pain, her chief complaint of fractured teeth. So now a higher quality of life, meaning something that she can confidently smile with and provide a better ability to chew. So due to her trismus, we were only limited to fabricating the maxillary denture. So that's what we went ahead and did. So this is an image of the impression and the pour up. You can see the defects within the maxilla, but we were able to work around these. We mounted the case parallel to a floor. And again, you can see on this top right image, this, the bony protuberance there. We couldn't, do an avioplasty in the OR just because of the risk of developing ORN. And so we kind of had to work around this, and we set the teeth from second premolar occlusion. So this was the day of delivery. She was very, very happy with this result. She cried and hugged Dr. Randazzo and myself. Probably one of the best dental experiences in my young career. Very pleased with this, was very confident with her smile now. And so I think we provided her with the great care even after all of her complications. So you might ask, and I'll go back quickly to this radiograph here, why haven't these mandibular right implants been loaded? Well, this patient developed exposed plate and a draining fistula, constant draining fistula, and then that right angle of the mandible. The head and neck service believes she has ORN within the fibula. And you can see in her picture here, that bandage or the dressing on her right side of her face is she changes that pretty much every other day or every day, twice a day, just because this fistula is always draining purulence. So that's the reason why we haven't loaded those implants. And right now the patient's getting by with eating harder foods, more substantial foods. Obviously she isn't able to chew well with the harder meats like steak, but she's able to increase her diet to eggs and soft foods like noodles, which she couldn't do before the surgery. So I want to thank Dr. Randazzo and Dr. Shim for helping me out in this case. In Dr. Randazzo, as everyone knows, is a board certified prosthodontist and a wonderful dancer, but he was actually able to actually instrument some canals in the OR, which is really cool to see. So thank you both.
All right, good job, Andrew. Very nice. Dr. Shem.
All right, so I will share my screen. All right, so good afternoon, everyone. It's a real pleasure to be able to share this interesting case with you of intralesional steroid injections for intraoral Langerhans Cell histiocytosis. It's not exactly straight dental, which has been a real treat to be able to see another side of oral management for these cancer patients. A little bit about myself. I grew up in the San Francisco Bay Area, near Berkeley, California. I miss it every day. It's a view just over my university. Afterwards, I went to Temple University in Philadelphia for dental school, and I, similar to Dr. Pishek and the Cubs, I was able to see the Eagles win their first Super Bowl in many years, which is great. After that, I went to Cornell, New York Presbyterian Cornell, across the street, and while in New York, I've been able to enjoy a lot of great pizza. For those of you who've watched The Office, this is the best pizza in New York, right behind me. After that, just like Dr. Iovino, I was able to get a taste of what it was like to work at Memorial Sloan Kettering. I got hooked and made my way over there for this year. That's me with Dr. Pishek, one of the best co-fellows I could ask for, helping out a patient in the OR. After that, after this year, I'll be headed to New York Presbyterian again at Columbia to complete a residency in oral pathology. So this case here is patient CZ. She initially presented to us in February 2019 as a 44-year-old female with Langerhans Cell histiocytosis, referred for evaluation prior to radiation therapy for some submandibular and thyroid lesions. In terms of the history of her Langerhans, in 2002, she had developed polyuria and polydipsia that was unexplained. Later on, in 2010, she developed hypothyroidism and amenorrhea. And at that point, she was diagnosed with diabetes insipidus, and she was started on desmopressin. The following year, she had a pituitary mass that was biopsied and revealed a ganglioglioma, and it was recommended observation for her at that time. The subsequent year, she developed an anterior neck mass, and the biopsy of that mass was diagnostic for Langerhans cell histiocytosis, CD1A positive and BRAF V600E negative. She was then treated with vinblastine, mercaptopurine, and prednisone at an outside hospital through 2013. So she had remission for several years, and then in 2017 developed left ear drainage, loose teeth, and a left neck lump. PET at that time showed enlargement of her left submandibular gland, and an outside biopsy of the gland revealed Langerhans cell again. She also had outside biopsy of the hard palate and mandibular gingiva, which also showed Langerhans cell. And so she transferred her care to MSK at that time. So a little bit about Langerhans cell. It is considered a rare neoplasm of histiocytes. Its incidence is about 1 in a million in patients older than 15 and up to 9 in 1 million in children younger than 15. Historically, you might have known of it as histiocytosis X, which covered a spectrum of diseases such as Handschuler-Christian, Lederer-Seaweed, and eosinophilic granuloma. And the majority of these patients present with bone, cutaneous, and pituitary lesions. So the reclassification of Langerhans cell histiocytosis into a histiocytic neoplasm was quite recent, and it's actually part of a family of other histiocytic neoplasms divided into 5 major subgroups: the L group, C group, R group, M group, and H group. Each has its own unique histologic and genetic features, and Langerhans would be considered in this L or Langerhans subgroup. So given that these conditions are considered now neoplastic, MSK has been able to leverage its abilities to help find these patients care for these otherwise rare diseases. So at MSK, we have the ability to take the tumor and blood samples and sequence their genomics. And then taking that data, we can correlate it with their the genetic profiling of these tumors, and then take these patients and then place them into clinical trials based on their genetic mutations rather than their tumor biology, or rather than their location of the tumor. So instead of having a trial designed for like lung patients or a trial designed for breast patients, what we can do here is actually classify patients based on their BRAF mutation or their EGFR mutation. So this has given opportunities for patients with rare diseases to actually gain access to certain treatments that may be effective for managing their neoplasm. And so, for example, for these histiocytic neoplasm, this was a paper published recently in Nature Letters showing that patients with MEK mutations for histiocytic neoplasms actually have halted progression of their disease while on this medication. So in terms of this patient-specific management, she had impact testing, which is what the test is called at MSK Impact, which showed an in-frame deletion of BRAF, and she was given the option of cytarabine, which was the standard chemotherapeutic treatment at the time, versus clinical trial on cobimetinib, which is a MEK inhibitor. And so she was on cytarabine from January of 2018 to November of 2018 with good response. However, subsequent PET did show that she had residual disease in her thyroid and submandibular glands. And so this is when she was referred to radiation oncology to evaluate for treatment. Ultimately, the patient refused further systemic management and opted for local management of her lesions. And so this is when she presented to our service. So this is her panoramic radiograph from that initial visit. In terms of the cortical bone, you'll see that it's normal trabeculation. You'll see in the right maxillary sinus, she does have a well-corticated focal radiopacity, thought to be maybe a mucocele or a pseudocyst. In terms of any other sort of abnormality on this panoramic radiograph, you might note some mesial vertical bone loss on the mesial of number 13, which is actually the site of the lesions that we noticed intraorally. So again, on the picture on the left, you'll see that she has 2 ulcerations of her hard palate. One is directly interproximally between numbers 12 and 13, and the second ulceration more medially towards the midline. On a bite wing radiograph, again, you can appreciate some generalized moderate bone loss with some severe vertical defect on the mesial of number 13. So because she had just completed her systemic treatment for Langerhans cell, we rebiopsied the left palatal gingiva, which confirmed the diagnosis of Langerhans cell with CD1A and S100 positivity. In terms of her treatment going forward, because she had decided to not go forward with systemic treatment and local treatment, in discussion with her medical oncologist, we were thinking about what we could offer her. In terms of, this is when we came across these intralesional steroid ejections, which for Langerhans cell, generally speaking, has been well documented with good effect. And more recently, there were some scattered case reports about effectiveness intraorally as well. So in discussion with her medical oncologist, we decided that we would give this a shot and see if we would be able to help stabilize her disease while she avoided more systemic treatment. So this is how we managed her. So from June 2019 to February 2020, she had intralesional triamcinolone injections to these ulcerations between 40 to 60 milligrams every month. From February 2020 to August of 2020, she did have a break due to the COVID-19 pandemic. And then in August 2020 till her last follow-up, she resumed these intralesional injections. In August, she did develop a periodontal abscess after one of these injections, which resolved after oral and IV antibiotics. And then we noted in January of this year that she also developed a recurrence of a left mandibular gingival lesion. So some pictures to demonstrate the results. So again, these are the two lesions. We started in August, and those are the two sites where we would infiltrate the steroid. And then in February 2020, when she had, right before the break in her treatment, these pictures were taken, which show a reduction in the erythema as well as the size of these lesions clinically. However, you'll note from these buccal views that she did have progressive bone loss interproximally between these teeth. And so then looking at the images from February of 2019, her initial visit to her most recent visit, again, you can see interproximally between 12 and 13th, the progressive bone loss, and pretty much stability and no changes anywhere else on these imaging. So looking at her whole entire sequence of treatment, you'll see in February 2019, where she started, in February 2020, this improvement in the size and color of her lesions. And then January of this past year, a near resolution of the more medial hard palate lesion, but increased intensity of the color and size of the interproximal lesions. So where do we go from here? In terms of her management, we're going to continue to treat these intraoral lesions with the injections. Number 13 is grade 2 mobile and has intermittent cold sensitivity, likely to the root exposure. We've had discussions about, do we root canal, do we splint these teeth, when to extract. But ultimately, we want to try to maintain these teeth as long as we can for her and make sure she's asymptomatic. She does continue to defer additional systemic therapy as she is considering pregnancy, and systemic therapy would kind of prevent her from being able to pursue that. And so she's going to receive these intralesional injections intraorally, as well as continue to receive intralesional steroids to the submandibular and thyroid glands with interventional radiology. And so as of her last PET scan, she has stable disease. And so that I'll turn it over to our Max Face Fellows as they present their cases.
Very nice, Dr. Shum.
Sorry. All right, so good afternoon, everyone. My name is Jenny Nguyen. I am one of the Max Face Fellows this year. And so today I will be discussing a case regarding the rehabilitation after resection of an extensive buccal mucosal squamous cell carcinoma. A little bit about myself. I am originally from Northern Virginia. I stayed in state and went to the University of Virginia, Wahoo Wah. After my undergrad training, or undergraduate education, I moved to Charm City, aka Baltimore, Maryland, where I did both my predoctoral dental training as well as my 3-year prosthetics residency. And then after that, I moved even further up the East Coast and had the opportunity where I am now to do the Max Face prosthetics fellowship training here at Memorial Sloan Kettering. After this year, I will be finally able to start paying off some of my loans that I accumulated over the last 7 years, and I'm actively applying for jobs and interviewing at this time. So today we will be discussing Mr. D. Mr. D first presented to the Memorial Sloan Kettering Dental Service in early 2009 as a pre-chemo RT dental eval. At the time, he was a 52-year-old male with a history of squamous cell carcinoma of the right buccal mucosa, status post-surgery and neoadjuvant chemotherapy that was performed at MSK the previous month. He had undergone induction chemo due to the extensive size of his original tumor, which was about 4 centimeters in size. The surgery involved excision of the buccal tumor via through and through resection of the overlying skin, a modified neck dissection, right segmental mandibulectomy, a right maxillotomy, tracheostomy, and a free flap reconstruction with a rectus abdominis flap with soft tissue only. Mr. D was PEG dependent due to post-op dysphagia. He had a history that included cigarette smoking, chewing tobacco, and about 10 years usage of betel nut. So as you can see from the panoramic radiograph obtained at that time, he had undergone total removal of the right side maxilla and mandibular structures without any bony reconstruction. And while Mr. D presented clinically with poor oral hygiene, he was noted to have no carious lesions, no mobile teeth, no restorations, and no bony lesions, and was thus cleared to proceed with chemo-RT, which was completed to 6,000 centigrade with concurrent cisplatin a few months later. Over the next few years, Mr. D continued to experience some challenges with eating, swallowing, and chewing. He was noted to have malocclusion with mandibular deviation to his right and therefore left-sided malocclusion, and he remained PEG dependent. He continued to see speech and swallowing and rehab medicine during this time. He underwent revision of the flap with plastics with the understanding that this would only debulk the volume of the mouth, but would not improve his swallowing or ability to eat. And therefore, this procedure was only going to have some limited functional benefit. His issues were related to the loss of the posterior tongue, the pharynx, and the musculature as due to radiation. Despite this information, the patient continued to make several inquiries about surgical reconstruction. Multiple surgeons here determined that this would be an excessive risk due to his complex previous surgery and resection and his radiation history, and likely any surgeries that would be done would still not improve his malocclusion or function. In terms of dental, the patient had a pretty poor follow-up during this time period. Palatal ramp prostheses were delivered to attempt to allow the mandibular teeth to contact during eating. His dentition was noted to deteriorate and he was developing some caries, but he really didn't come to dental very often during this time period. In 2016, the patient went to an outside facility where he was reconstructed with a fibular free flap and an ALT right facial reconstruction. These areas were revised a couple of times as well as at that outside facility as well. Fast forward nearly a decade after his initial presentation, to July of 2018, Mr. D presented back to MSK Dental after all of this other reconstruction with additional surgery planned. His chief complaint remained the same. He wanted some cosmesis and something to improve his speech, eating, and swallowing. As you can see here, the multiple sites of reconstruction, specifically at the right side of the face. He has some facial asymmetry with concavity of the right middle and inferior 1/3 of the face. This is due to the radiation-associated soft tissue fibrosis and atrophy. The scars along the right cheek, and then obviously the radiation of this radiation-related changes of the skin on the right side of this face, and his neck is fibrotic after all of this treatment. Up close, we note that Mr. D has issues with both mouth opening and closing. As you can see here, this is Mr. D with his lips closed as much as he can, and we note the right oral incompetence. Partially, this is due to the atrophy of the lips from the procedures and scarring from surgery. Mr. D also had issues with mouth opening. Again, partially due to the scar contracture along the right oral commissure and as well as the attachment of the flaps to his native lip. Intraorally, Mr. D was noted to have generalized caries on all his remaining teeth. There are root tips present at numbers 13 and 19 positions, and 13 would actually had purulent discharge. Despite this presentation, Mr. D was asymptomatic on all of his teeth. And as you can see in the bottom left image, the right side of the oral cavity is completely obliterated after his surgery. So this is the Panorex obtained in 2018. You can see the fibular reconstruction of the right hemimaxilla and hemimandible without condylar reconstruction. The healing of the osteotomy looked pretty good, but as you can see, the progression of caries is radiographically evident with caries basically on all of his remaining teeth. Surprisingly, number 15 is the best looking tooth in his mouth, despite what I think is the hardest place for him to reach. So here are the intraoral images of the teeth at that time. Mr. D was intending to undergo additional surgery, so some fat grafting to create lip competence and a commissurectomy to allow him to open more at the outside facility. Since he was going to have that procedure done while he was under, the plan was to also have number 13 extracted during that time. Number 13 received a slightly lower dose of radiation, so the risk for ORN was perceived to be slightly less in that area. However, number 19, which was also a set of retained roots, received a much higher dose of radiation, and the plan was to have those teeth, allow those roots to exfoliate. As for the remaining teeth, the plan at the time was to endodontically treat and place root locators wherever possible, and then to restore with maxillary mandibular resection prostheses from there. So all of this occurs over the next few months, basically up until the COVID pandemic occurs. He does undergo that procedure at the outside facility to have an attempt to open his mouth a little wider. 13 was extracted, the root canals were done, and root locators were placed at teeth 11, 12, 14, 22, and 23. So fast forward through the COVID pandemic 6 months to our current class of fellows. Mr. D presents back to the dental service. His chief concern has not changed. He still wants teeth for smiling and chewing. However, he now indicates that he has some pain and bleeding on the mandibular anterior gingiva when he's brushing. Intraorally, he's noted to have a sinus tract buccal to number 23, which we traced, and the tooth was tender to percussion and palpation. Otherwise, his extraoral and intraoral presentation was relatively unchanged. His oral hygiene had not improved, and he still had trismus despite his most recent surgery with a maximum mouth opening of 27 millimeters. What doesn't sound so bad until you realize that this number is from root surface to opposing root surface, because if these teeth had full crowns, that number would be dramatically less. So this is just a summary of Mr. D's presentation at the time with some dental models we obtained. So there are root locators present on 3 of the maxillary teeth and 2 of the mandibular teeth. They are partially submerged, but otherwise there are no caries except for on the root surfaces of number 19. Numbers 20 and 21 are grade 1 mobile, and number 23, which is where we trace the sinus tract, was grade 2 mobile and very, very painful for him. As people have previously discussed, Dr. Singh helpfully does our contouring, and she did so for Mr. D. So number 23 is down here, which we consulted with both endo and oral surgery regarding trying to remove the perforated, the root locator that was perforating and try to repair it versus extraction. The consensus was that removal of the locator would risk fracturing the root and possibly traumatizing the bone even further. And the recommendation was careful extraction to basically stop the spread of infection. So some factors to consider for Mr. D. Mr. D's, regarding his trismus and oral incompetence, he'd had numerous surgeries and revisions and basically still had the same issues. In terms of his dental surgical needs, he's undergone high-dose radiation to the oral cavity and is therefore at risk for developing osteonecrosis. So we have to address the fistula, which is kind of an urgent situation, but elective procedures such as pre-prosthetic surgery would be contraindicated. In terms of his dysphagia, most of this is beyond the realm of prosthetic assistance. There's reduced oral control and oral spillage from the right lip, and his problem is also related to the radiation impact on the musculature. And finally, the entire right half of the oral cavity is obliterated by the flap. So we had to let Mr. D know that we would not be able to provide him with a quote unquote full smile. With that understanding in mind, we updated Mr. D's treatment plan, obviously some patient education, a high fluoride toothpaste prescription, fluoride varnish. He's put on a regimen of antibiotics, pentoxyphylline, and vitamin E, and number 23 is extracted, shown here. Some odonoplasty is performed to expose the retentive cuffs of the locators. We plan to reevaluate the teeth number 20 and 21 for root canals if they become symptomatic, or simply allow them to exfoliate as they are already mobile. The plan was to give Mr. D a maxillary resection prosthesis with the understanding that this would improve aesthetics, but not likely be of much functional benefit, although we may consider incorporating a palatal lift to improve his speech down the line. And then finally, a discussion was had where we may give him a possible mandibular resection prosthesis or a bite plane. He understands that this, or he was made to understand that this was only a potential given the limited restorative space. And of course, he would be on a strict 3-month recall. So this is Mr. D. After cleaning up around the remaining teeth and the locators, we proceeded to border mold and make final impressions as one normally would, except with obviously just half of the arch. The main challenge with Mr. D's rehab comes predictably at the jaw records appointment. We already had a discussion of fabricating just a maxillary prosthesis and maybe a mandibular one down the line, but would have to be reevaluated given the space. Trismus, as we have tried to emphasize with Mr. D, is not the main issue, despite all the surgeries he's had to try to increase his mouth opening. Mr. D's main issue prosthetically is actually the lack of restorative space. Given the location of the ridges and with the radiation history, we could not surgically increase the restorative space with extractions and alveoloplasty as we normally would in a non-irradiated patient. So what's shown here is just the maxillary record base and the wax rim setup with the appropriate incisal edge position, occlusal plane, buccal corridor fill, and lip support that we determined at this appointment. But you can see how thin it is. And the perforation that we see right here is actually the cusp of number 15. So some things to consider. With the limited restorative space, we could not fit the mandibular wax rim at all. I basically destroyed it during this appointment with trimming it down to get him to a vertical dimension where he could actually close his lips. We can't increase his vertical due to his oral incompetence. And since I didn't have a mandibular wax rim, I had to figure out how to maintain the vertical dimension that we were planning to keep and transferring this relationship to the lab setting, as we couldn't fit a face veil due to the flap covering the entire right side. So the solution was that we attached a second wax rim to the maxillary wax rim. So this provides some stability with hard wax. This maintains the vertical dimension using the hard stops in the manner with the locators and the remaining root surfaces. The outline of the original wax rim maintains the occlusal plane, incisal edge, buccal corridor, and so forth that we would typically establish during this appointment. And this second wax rim, once everything is mounted, is easily just popped off with a buffalo knife. So here's Mr. D's case mounted parallel to the floor. Again, couldn't fit a face bow, so we did the best that we could. But what this really shows is the limited space that we are working with. So this is Mr. D at his wax try-in appointment. The top image is him without anything in place, and the bottom image is him with the wax try-in. Mr. D, even at this appointment, kept asking that if he could increase his mouth opening with more surgery, if we could fit something on the bottom, on his mandible. But as you can see here, he didn't have any lip competence as it was. Even with the maxillary teeth, we noticed that the lip incompetence is even greater, even without a mandibular prosthesis. Increasing his vertical dimension to add something on the mandible would only worsen this. It wouldn't provide that much of a functional benefit in terms of him helping him eat, since he would just have increased oral spillage and his swallowing ability would be unchanged. So once Mr. D and his wife understood the limitations and approved the wax try-in, we proceeded to process the prosthesis. So here's his maxillary prosthesis after processing. As you can see, it's just the left half of his upper jaw. We ended up having to open it up in the number 15 area rather than overlying it with acrylic because it was so thin. The 3 maxillary locators were picked up intraorally, and the black processing inserts providing with more than enough retention. So here's Mr. D with his prosthesis. His speech is slightly improved simply by adding the incisal edge position in the right location for certain sounds, his fricatives. His smile is he finally has a smile that his family approves of, as well as some improved lip support. And technically, he can quote unquote chew using the maxillary prosthetic teeth against the retained roots on the mandibular ridge. However, in terms of actually eating, he still can't safely swallow because of the dysphagia after radiation. So where do we go from here? As we discussed, we may incorporate an extension for a palatal lift, as his soft palate is somewhat incompetent. That might potentially improve his speech once he adapts to his prosthesis. In terms of providing a mandibular base plate for a chewing surface, Mr. D still really wants to try this, so we will actually be providing him with that at his next appointment, given the understanding that his lip incompetence will be increased. The take-home messages from Mr. D's treatment is the importance of a strict recall and a home care regimen that has to be strongly reinforced. The importance of diagnosis and treatment planning is really key here, as trismus is not the main issue, and that's, he underwent so many procedures to try to improve this, and at the end of the day, it didn't actually help him in terms of his chief complaint. So along with that, managing patient expectations, and despite the complexity of his oncologic treatment, his rehabilitation follows a very simple KISS principle, keep it simple. And with that, I'd like to thank my amazing co-fellows. Dr. Singh isn't shown in the photos, but she's obviously very much included. To the assistants and the office staff, and of course, all my attendings for their knowledge and mentorship during my training here.
Very nice, Dr. Nguyen. Dr. Kronstadt.
Yes, hello. Excuse me. Begin. Hey, good afternoon, everyone. It's my pleasure to present to you two current endeavors that I am working on during my fellowship year here at Memorial Sloan Kettering Cancer Center. I was born and raised in the suburbs of Fort Lauderdale, Florida. But before I became a dentist, I was actually a classical musician and a teacher of English literature, having studied English literature at Nova Southeastern University. You may have heard of their dental school. They also do have a small liberal arts school where I focused in British literature. Through a long story that is the subject of a completely separate PowerPoint, I somehow became a dentist. I attended dental school at the University of Pennsylvania School of Dental Medicine, or as they like to call themselves, Penn Dental Medicine. During that time, I developed an interest in prosthodontics, but prior to residency, prosthodontics residency, I did do a GPR up in Connecticut at Yale New Haven Hospital. I then pursued my prosthodontics training down in Houston, Texas at the Michael E. DeBakey Veterans Affairs Medical Center. That program is didactically linked with the dental school across the street in Houston at the UT Health System, of which MD Anderson is also a part, and there I completed my master's thesis. If any of you ever have the chance to go to Houston, I strongly recommend that you check out the Texas Medical Center. That picture in the lower right corner is not of downtown Houston. That is simply 14 massive hospitals. Yes, in Texas, everything is bigger. And there's a range of hospitals, including MD Anderson, the VA, Texas Women's, Texas Children's, and it is really quite an impressive, massive site. And you should definitely take a drive through it if you ever have the opportunity. So first, what I would like to do is just touch briefly on my current research project. What you see in front of you is an image from what we call the VSP, also known as the Virtual Surgical Plan, when a segmental mandibulectomy and fibula free flap reconstruction is planned. I am looking at a very specific aspect of the MSK experience in regards to the immediate placement of implants in the fibula free flap. And what you see in front of you is just kind of the overview. It shows the extent of the resection, the planned fibular segments that are going to be used to create the neomandible, the planning of the immediate placement of the implants within the fibula in terms of their position and trajectory, and making sure that they are engaged in as much bone of the fibula as possible. If you look at the right side of the screen and the upper image, you see the surgical guide in relation to a patient's actual fibula and how this is planned out, and how the plastic and reconstructive surgeon plans to place the guide on the fibula. Once that is done, the placement of the implants is rather straightforward. That's not to say that there isn't room for error, but it is fully guided and you have no choice but to go through the key and the sleeve and make your osteotomy through that sleeve. And provided that the guide is correct and the surgeon has placed the guide correctly, you will end up in the correct position. Where there is a chance for error is this concept known as inset. And the importance of this part of the procedure was actually outlined in a paper published by the MSK team involving both the plastics and reconstructive surgeons as well as Dr. Rosen when he was here on faculty. And basically, this refers to the importance of maintaining the proper buccolingual position of those fibular segments when they are attached both to the reconstruction hardware, which is then attached to the remaining native mandible. And if there is too great of a rotation that occurs, then this can render the implants in an unfavorable position, not only in relation to the remainder of the teeth in the native mandible, but also in relation to the opposing arch. If this is relatively minor, it does not have a huge effect on the resulting prosthesis, but in extreme cases, which does happen from time to time, the implants can be rendered either unrestorable or will greatly affect prosthesis contours. Here are two images from two different cases that were performed during the past year that I had the pleasure of working with Dr. Randazzo on in the OR. And you can see the importance of the concept that I just described, whereas we are restoring the majority of these patients with a fixed detachable modality. They will have a bar mesostructure that is permanently affixed to the implants with a superstructure that is removable that contains the prosthetic teeth. However, if the implants do not have the proper position, the bar will be placed in such a way that there will be unfavorable cantilevers placed on it, which can accelerate bone loss and create many, many complications with the prosthetic outcome. So the overall research flow is as follows. Every patient does receive a virtual surgical plan, and from that surgical plan, the software company does generate a resin model that is of that clear resin that you see in the second square. In that model are two cylindrical openings that represent the exact position of the planned implant placement. As part of their postoperative protocol, patients present to the dental clinic within 2 to 3 weeks of their surgery. Again, that depends on how well they've recovered and whether or not they're still admitted and how well they're doing, but generally around that time frame, and they do receive a postoperative a postoperative cone beam CT scan, so we can evaluate the implant placement as well as evaluate the osteotomies and look at the hardware. And we do share these images with the surgical team. From that image, a post-surgical model is generated. It is 3D printed, and what the research project entails then is looking at the surgically planned position as well as the in vivo actual result of the implant placement by comparing directly the two models that are generated from the images. So this is a retrospective study with a cohort of 10 patients. We have recently completed the 10th surgery for this cohort. This table would belie the fact that we do have the occasional maxillary reconstruction. However, the recent ones did not meet the inclusion criteria. And you can see across this table that we just have outlined the extent of the resection, the patient's age, their sex, how many fibular segments were involved, and how many implants were placed. 9 out of 10 patients in this cohort did have a diagnosis of squamous cell carcinoma, and there is one case of a fibula reconstruction due to ORN. So as of right now, our cohort contains 10 patients. The average age is 62 years of age. There are 24 fibula segments placed with 25 implants. So once all of the models are generated, we will then use anatomic landmarks that were not included in the resection on both models to obtain angulation and make comparative measurements. I would like to use my remaining time just to touch on an interesting case that is in process in the dental clinic. And this is a case of a digital prosthesis. And by digital, I don't mean digital technology. I do mean digits as relating to the human hand and foot. So I would like to introduce patient TW. She is a 63-year-old African-American female. In 2016, she was diagnosed with acrolentiginous melanoma of the left hallux. The hallux is the medical term for the great toe or the big toe. She initially denied treatment, but due to disease progression, she eventually underwent a transmetatarsal resection in 2019. She has received no other adjuvant therapy, and she remains NED. Her treatment plan is to have a silicone helical prosthesis fabricated. Now, we have an established referral base from Dr. Coit over in the surgical oncology service for digital prostheses to replace fingers for patients who do lose those digits due to melanoma as well. But for our service, this will be the first time a helical or a pedal prosthesis is fabricated. Some considerations that must be taken into account before starting. The first, obviously, is going to be retention. The prosthesis-bearing surface is completely convex, as you saw in the photo. There is no residual stump, and this is a highly dynamic anatomic position, especially in regards to ambulation. The prosthesis will not be weight-bearing, and there are some definite considerations to take into account when trying to make a moulage to generate a wax sculpture and eventual prosthesis, which we'll discuss momentarily. However, this patient is extraordinarily reasonable. She understands that it will not allow her or enhance her ability to go run any marathons. She just wants it purely for cosmesis. Not only does she only want to wear it in the springtime with sandals, but a very specific pair of sandals that she brought with her, which actually turned out to be rather serendipitous due to their design. So in that we had never made a pedal moulage before, I volunteered my own left foot to do a dress rehearsal of sorts in order to prepare to treat the patient. We ordered a foot casting kit, and it is exactly what you see, a plastic tub that we are going to fill with irreversible hydrocolloid. On the right, you see medical artist Marjorie Golden using an industrial paint mixer to mix 2 pounds of irreversible hydrocolloid with 5 quarts of water. Obviously, such an amount of alginate is impossible to hand spatulate without getting, to get rid of the lumps and to get a smooth mixture. According to manufacturer's recommendations, the proper procedure is to immerse the foot and then to slowly lift it out and then re-submerge it. This will avoid air bubbles and allow the material to flow completely around all of the anatomy. This particular irreversible hydrocolloid takes an entire 5 minutes to set, and that is a very, very long time. It is also much less viscous than intraoral alginate. Once set, the manufacturers recommend using a popsicle stick to create a releasing incision through which the foot can be released superiorly. However, we did find that this was entirely ineffective. So the lessons learned from this dress rehearsal moulage were the following. As the maxillofacial prosthetics resident, I understand the importance of keeping an anatomic feature still and completely non-flexed during the making of a moulage, and I had a significant trouble with that for that full 5 minutes, mostly because you cannot touch the bottom of the foot to the bottom of the container because that would distort the impression. So you have to keep it suspended in the material for the full setting and working time. And that proved to be difficult, uncomfortable, and caused muscle cramps. And during that, once that starts to happen, you start to move your toes, and keeping the foot relaxed and not flexed was very difficult. Most importantly, though, the popsicle stick recommendation resulted in just tearing of the material rather than a clean slice. So we had to use both a mixing spatula and a buffalo knife. And without sounding too much like a baby, that was actually rather uncomfortable because you have to slice all the way down to the skin. Once that incision is made, the manufacturers recommend that the slice is repaired with cyanoacrylate. But even when doing that, you do get a fin of stone once the model is poured. So it is human nature to just kind of cut down the middle of things as we did during our dress rehearsal, and that resulted in a giant fin of stone right on top of the anatomic area of interest. So we modified this procedure by using a stack of ceramic tiles secured with beading wax at the bottom of the container, and that was a stop for the patient's heel because the heel is not critical anatomy in this prosthesis. We marked the side of the container so that we knew where to create the incision lateral to the site of the former site of the great toe, so we would not get the stone fin in the wrong spot. And this just required a lot of verbal coaching during the procedure and during the releasing incision for the patient, and she tolerated it well. Going through all of this impression making in such a exaggerated way, it must be noted that I'm sure in the future there's a role for digital technology and scanning in creating models for these type of prostheses. So we obtained the master cast and cast of the contralateral foot for a sculptural reference. You can see that the irreversible hydrocolloid gave us the desired accuracy. And we can view the sites from both the superior and the frontal views. There was concern initially looking at the master cast that she may have flexed her second toe because it didn't seem to be in the exact spot that it was when the patient was relaxed. However, this has proven not to be of significance. The initial try-in of the wax sculpture and the sandals that the patient wants to wear shows the serendipitous nature of her shoe selection. The transverse straps are doing a good deal of the heavy lifting in terms of the retention, even though we're going to have an additional silicone retention sleeve for the prosthesis. The patient is mostly concerned with symmetry with the contralateral great toe. She is not concerned with harmony of the remaining toes on the side of the foot with the defect. So she wanted to ensure that we had the correct curvature, length, and nail contour that would be as close to symmetric as possible with the contralateral side. The patient is also very concerned about the color and the shade matching. She does not want it to match the somewhat dark patch that is adjacent to her surgical site. Again, she is concentrating on matching the shade with the contralateral toe, and she also wants there to be a natural transition to the plantar surface. So these were some of our initial shade matching. The patient returned then for a final trying of the wax sculpture, during which some of the contours were refined, and some of the surface details were also refined, and the patient was very satisfied with the nail contour and the length of the wax sculpture. In addition, on the image on the right, we can see that we've very closely matched the lighter skin tones in the parts of the foot, and this is what the patient wants her prosthesis to match. So the patient will return for completion of the prosthesis in the upcoming weeks. I want to take a moment to thank Dr. Huryn for not only his role as attending on this case, but for his efforts as chief of the dental service. A brief thank you to Dr. Randazzo for his tireless efforts as program director of the Maxillofacial Prosthetics program. And of course, a great thank you to Marjorie Golden, our medical artist, for working with us on this case. Thank you.
Okay. And last but not least, Dr. Singh.
Welcome. Thank you. Good afternoon, everyone. It's a great pleasure for me to present today my research experience at the dental service of at MSK. Before I start, I will just give a quick introduction about myself. I completed my dental training in 2007 and began my journey as a dental oncologist in 2011 with the inception of a huge comprehensive cancer center in the eastern part of India. And it also caters to the patients from the neighboring countries like Nepal, Bhutan, and Bangladesh. And this is located in Kolkata, which is the eastern part of the country. And it is also known for yellow taxis and Howrah Bridge. And these are my colleagues with whom we started our head neck oncology practice with my head neck consultants and friends and colleagues. But apart from the excitement of working in a comprehensive cancer center, there were always obstacles that stood my way, including my limited experience in treating cancer patients, lack of mentorship, lack of formal training, which was available in the country. But the setup was in early stages, and then I had enough and more time to learn board and get updated with the current practice guidelines, attending conferences, national and international clinical observerships. It was on, and I did have a good clinical experience on the center, but it was only in 2014 that I had the good fortune of visiting MSK, which was totally an eye-opening experience for me. And I was able to fully explore the scope of dental oncology. I had spent the time in the clinics with Dr. Huryn, Dr. Estello, Dr. Randazzo, and in the lab as well. And also spent a great time in MSK. This is the batch in 2014 with my dear friends, and in the lab and inside clinic, outside, and otherwise. But there was always a need for research with the center getting busy and growing, and the growing number of patients. There were these challenges which were growing in my practice, which in growing complexities that I always came across on everyday basis. There were always unanswered questions of why, how, when, why not, why this. And it was time that it was to take for the next stage in my training and research experience to bridge the scientific gap between the chairside inquiries which patient had and to work towards the improvement of patient outcome. And this is why I felt research was important to increase my knowledge, to improve evidence-based patient care or prevention of disease, to improve the quality of care and for professional development. And I started my research journey with this workshop, which was held in Australia, in Sydney in 2016. It was, most of these participants were medical oncologists, and there were only 2 dentists whose proposals were accepted for this workshop. And I was fortunate enough to be one of them. And then I decided to pursue a research fellowship at Dental Service MSK in July 2019, to learn into about research in depth, about the instruction and design, the method of assessment, some basic statistics, the data analysis, of course, manuscript preparation, and I would also say a manuscript submission, which is also a learning experience, and ethics of clinical research. And my journey so far has been interesting. I'm going to share a couple of my studies, which I have worked on and still working and is going on. So this was this was one case report, which was titled as Multiple Myeloma, Masquerading as Medication-Related Osteonecrosis of Jaw. And it was about a 67-year-old female patient with a history of multiple myeloma and post 28 doses of IV bisphosphonate, and who was referred to the dental service with a suspected medication-related osteonecrosis of jaw. And if you see the pictures, there was the spanographic radiograph showed changes, but the excisional biopsy was inconclusive, and there was a CT-guided biopsy, and the histological analysis showed that it was plasma cell neoplasm, and the patient received 20 grays of radiation, and post-radiation, the bone, there was this immobile bone which was teased out with tweezer under the pontic area, and this was the follow-up image. And this could have been easily misdiagnosed as a medication-related necrosis of jaw. But this is how we thought it would be important to write on this topic. The other interesting review article which I wrote in the dental service was about the prosthetics of prosthetic devices, which with an aim and these prosthetic devices basically, they protect and displace the vital structures and assist in positioning of the treatment beam, carry radioactive materials, and all with an aim to maximize the radiation dose to the target volume and minimize the toxicities, which the acute and the chronic toxicities which are associated with radiation. We usually see the toxicities, but we tend not to think about these small radiations which make a big difference. And we did write, we have still submitted a paper on this, although there's not much on this. There are many papers, but there's nothing collective together. So we wrote a paper for the general dental practitioners and the radiation oncologists, just for their information, like the radiation, the shielding prosthesis, the occlusal, the radiation night guard, and the mouth opening devices, which is used as MSK, and the positioning stents. And this is our own positioning stent, which was fabricated by a 3D printer at MSK. Another retrospective study which I would like to mention about the role of conservative management in patients with medication-related osteonecrosis of jaw. Our experience in treating 112 patients who were on 3 most frequently prescribed anti-resorptive medications and who were diagnosed with MRONJ and treated with and followed at least a minimum of 12 months after the diagnosis, and we studied on these patients and realized that 51% patients had complete resolution or improvement in symptoms after close follow-up and conservative management, including chlorhexidine mouthwash rinses or antibiotics. This is an example of one of the patients who developed a grade 2 osteoradionecrosis, medication-related osteonecrosis of jaw, and with conservative management, which healed very well. And this is one of the recent publications which we had with the pediatric oncology group, and this was about the mandibular metastasis in neuroblastoma. Although the metastatic involvement in are commonly known of the more bony sites, including cranial bones, but the specific mandibular metastasis and the specific dental outcomes was not reported, and we thought it was a good idea to publish. And very happy to say that we are the first and the largest series so far reporting on 29 patients. And here is an example of an MRI showing an osteolytic expansile lesion and also a soft infiltrative tissue. And in our center, the most commonly metastatic site involvement was in ramus of the mandible with 55%, followed by the angle of the mandible. And although the panoramic radiograph shows just a unilocular radiolucency, like any other metastasis, but it is worth a look at. And this panoramic radiograph, it shows hypodontia, microdontia, and abdominal root shortening in a long-term survivor who was almost 13 years later, who is now undergoing the dental rehabilitation and severe and management for severe trismus. So we realized that mandibular metastasis, when diagnosed, when detected at diagnosis, is associated with prognosis similar to that for other skeletal metastasis. And radiotherapy is effective for control of mandibular metastasis with its own toxicities. The dental findings at the follow-up of the completion of neuroblastoma therapy included hypodontia, calcification of enamel and trismus. And that's why significant dental abnormalities post-therapy warrant regular dental evaluations. And this was my fellowship year 2019-2020, where I spent a real good time with my fellow colleagues and the attendings, and we had a good time at the, I did attend a maxillofacial prosthetic conference with Dr. Indazzo and my MaxFace colleagues, and had a great time. Now, moving forward, we have several ongoing projects like the validation of the MSK Face Q questionnaire based on the patient-reported outcomes and saliva measurement, their dentition status and quality of life studies, toxicities associated with proton radiation therapy in head and neck cancer patients, and many other studies which we are collaborating outside dental, including the radiation, pediatric oncology, and medical physics. And we also maintain the database for the newly reported ONJ cases in an Excel sheet. And I'm happy to inform that the ORN data is now transformed into an electronic database for all the osteoradionecrosis patients and also for the saliva measurement, and with the ease of exporting data for further analysis and studies. And the most interesting part of this research experience is contouring of the teeth structures to obtain the maximum and the mean dose of treatment planning for treatment planning to prevent osteoradionecrosis of jaw. And I must tell you that during this COVID time, it has been, this experience, this learning of contouring has really been helpful to patients who could not reach to MSK for dental help, and they were consulting the local dentist, and we were able to provide the contours to guide them from here. So as most of you all will recall, this is the contouring of in the top module for patients who were treated before 2014, and the various steps of it, like the contouring, and then the region specification, the dose calculation, and the DVH analysis. And we also are doing a lot of contouring in the Eclipse module, which is all these patients are for IMRT. And slowly with, and then the generation of the DVH, which gives the max and the mean dose, and it helps our attending to take a decision for decision making and treatment planning for patients who report to dental service post radiation therapy. And once these are contoured, these doses are mapped on the panoramic radiograph for the convenience of the for reading and reading. And also, we're happy to inform that we are able to, we are slowly moving towards the proton radiation. Most of the patients who are coming in have received proton radiation, and we are also trying to look into the radiation contours for these patients. And for example, this patient is a left buccal mucosa who received the proton radiation, and you can see the most of the doses were concentrated on this. And this is because the proton charged particles, which have the unique physical property of Bragg peak, that deposit the entire dose so that the contralateral rose receives barely no radiation. And as I follow the footsteps of all the radiation oncology, the research fellow, I continue to sit in this room, and I hope that I would be doing some more research work. Every day has been a great learning experience, every step. And I'm really fortunate that and honored and privileged to have my entire training from clinical to research, the experience of learning about newer drugs, about the newer radiation techniques, about the metastatic lesions, the contouring experience, and of course the dancing experience with Dr. Randazzo. And I'm really and all the research experience at the Center of Excellence. And I thank Dr. Huryn and Dr. Estillo for giving me this opportunity. And although I'm 1,000 miles away from home, I do feel at home with the most lovely and warm people at MSK Dental family. And of course, the yellow taxis, the Queenborough Bridge, and the subways at New York as well. And I continue my fellowship for the next academic year as well. Thank you.
Well, thank you, Dr. Singh. Thank you all.
Thank you.
Very proud of all of our fellows. You've done a fantastic job. And I just want to see if I can share my screen for the final slide. Okay, so we're running a little over. We've lost some of our audience, but I want to thank Dr. Yam and Carlene on the dental side for arranging this meeting. Obviously, Keith Yearwood and Jen Cruz from the Alumni Society, and a shout out to Kimberly Goyamphi for doing the video for Arnett. I want to just introduce Keith, who wants to say a couple of words to us for the Alumni Society. So, Keith, can I leave this slide up or?
Sure, you can leave it up. I'm not going to take up too much time. I just want to thank everyone for being here. My name is Keith Yearwood. I'm the manager of the Alumni Office. I appreciate that everyone was here to attend the meeting today. I also want to remind all of you that this was a CME accredited meeting. So anyone that wants to claim CME credits, just contact the Alumni Office. You can either email me or you can contact us through the Alumni website. And then you'll receive an email from us with instructions on how to claim your credits. We want everybody to have the opportunity to claim your credits. So if you have any questions, reach out to us through the, as I said, the Alumni website or by email. You can log on to the Alumni website, send the email that was sent to everyone. Once you get into the Alumni website, we want you to take advantage of reviewing some of the past videos, some photos from past events, meetings, even our past dental meetings that we've had, some MSK news. Take your time, browse around, and feel free to let me know what you think. So once again, thank you very much, and I look forward to next year's meeting.
All right, and thank you, Keith, for all of your support over the years. So in the last couple of minutes, I will ask all of you muted people to unmute, put yourselves in gallery view. I see some familiar faces. Dr. Ade Awosho, haven't seen you in such a long time. How are you? How are you? And again,
Hello, everyone.
Dr. Bowley, haven't seen you
George.
in ages.
Hey, George. Hi, everybody.
Ron Koslowski, wow, that's a blast from the past. How are you?
Hi, Joe. Great to see you.
Hey.
Great program.
Yeah, I see Dr. Bobby's name.
I see Dr. Gunaim. Hi, Dima. I miss you all. Miss you.
Yes. Let's see who else we have here. I see Dr. Skendry.
Where's Jeffrey?
He's shy. Debbie Lee, one of our in-town colleagues. Who else? Arvin.
Hey, Arvin.
Hey, Arvin. There's Ryan Lee. Hi, Ryan.
Ryan, yeah.
Hello, everybody. Oh,
Nice to see everyone.
one thing
Oh.
we wanted to mention also is that we're trying to update our referral database. If you are interested in us referring patients to you, especially those who are not so near, like some of our patients reside in Florida or Chicago, and we'd love to refer patients your way. If you'd like to be on that referral list, if you can just forward your email to Carlene, that would be really helpful so that we know that we can forward our patients your way.
Right. And you know what? Join the Alumni Society. It's free. So this way you can get in on the the alumni listing for all surgical, medical. A lot of times I'll get a call from out west or wherever, and they say, oh, I need a dental oncologist, or I need a maxillofacial person, and it would be so much more convenient if we had your contact information, or even just to have it listed with the Alumni Society, and they can look you guys up individually. So nice to see all these friendly faces, and hopefully we will see you in person next year. Let's see, anybody else? Okay, I think we're running over. We lost some of our audience. Thank you guys for staying on. And
Be safe. Hopefully we'll see you guys soon.
Yes, and you'll hear from us for sure.
Good to see you all.
Yes.
Take care, everyone. Nice to see everyone.
Helper.
Well,
Hey guys, hey
Take
JP,
care,
how you
guys.
doing? All right.
Dr. Halpern, how you doing?
Everybody's looking good.
Bye,
Yes.
guys.
Yes.
Hey George,
Hey,
how you doing, bro?
I'm all right. How about yourself?
Staying out of trouble, but that's boring. How's the family? How's everything going with you?
We're doing okay.
All right. Your kid's got to be driving or in college by now, I guess.
He just turned 13 a week ago.
Wow.
Oh, there you go. He's a man.
Yep.
Well, congrats. Glad to hear that.
Thank you.
That's wonderful. JP, congrats to you too.
Yes.
Oh, thank you.
Yeah, that's great. Glad.
Nice to see you, James. Thanks for a good talk.
Oh,
I'm
no,
glad the
thank you.
contouring's helping you.
Oh, yeah,
everybody was great.
I still rely on it. So I
Wonderful. Thanks
Saw
for all your
Mario
help.
for a second there, but I guess
Yeah.
his
I
daughter.
saw Mario in the beginning.
Yes,
Yeah, I
yes,
saw Mario.
yeah.
Actually,
By the way,
Dr.
the-
Slalo was here, but
Dr.
I guess he
Slalo
had
was
to
here.
leave.
Yeah.
And Dr. The tribute to was wonderful. I can see some of the things I said is on the cutting room floor, but that's editing for you.
Yeah, well.
Hey, but it was a great tribute doing that, and
Yeah.
God, unbelievable. Well done.
And we all miss her.
Hey,
All right.
Joe.
Indeed.
Joe.
Yeah.
Oh, that's Z right
Oh,
there.
you're on that. Okay. Show us your face, Z.
It
Z,
should
Z,
be
let me
on
see.
there. I don't know
Let's
why
see
it's
your-
not on. It should be, Joe, one thing.
Yes.
These residents, Andrew, Dennis, Jenny, Dr. Kronstadt, and Anna, you took it to a different level. These
Yeah.
people, they should stay there for another couple years.
It's been a good year. This is a very,
these
very
were
good
great
team.
presentations. And,
Thank you.
and
Otelo, I want to wrestle with you.
anytime, sucker. Hey,
Hey,
the
man.
last presentation that that Kenneth did, why not put a brand mark implant in the bony structure?
Been radiated.
Oh, it's been radiated. Because that was brand mark's first thing, was to
That's
put
right.
them in stumps,
That's right.
toes, and yeah.
Yep.
Yeah. The bicycle riding patient.
That's right.
2 prostheses.
Yeah.
That was crazy.
May I add one thing?
Sure.
In memory of Annette, and Lensana was here this weekend. He cried like a baby, but he wrote a short poem for Lynette. Annette may have gone to church every Sunday, but more importantly, she entered and touched our hearts every single day. Annette was a caring, loving soul. She never judged people. Instead, she accepted everyone for who they are. May her soul cross over to heaven and beyond.
Wow.
We may have lost a saint on earth, but heaven has opened the door for one of the most beautiful and beloved angel earth has to offer. Tears fall, lakes, oceans, and rivers freeze, but our hearts might be broken. But the thoughts of Annette being in God's house pleases. You know, Annette and Anne Marie and Mario were so important in his, you know, in his good memories and in his development. What a wonderful tribute you guys paid to her. It's just beautiful.
Yeah.
I mean,
Yeah.
this was a beautiful, the whole thing was a beautiful presentation.
Well, you know, we were prevented from doing an in-person thing because, you know, I mean, she died on the day I was on my way to Chicago for that meeting, and the hospital administrator actually called me. So that was, you know, sort of the end of February, and we were going to do something for her in March, and this whole COVID thing started, and you know, so we're delayed by a year, and even so, we're doing it virtually. But I'm happy we finally did something for her.
Yeah, it was
Steiner.
beautiful.
That's a blast from the past. How are you? Okay.
He's muted.
Muted.
Yeah.
All right, guys.
Where are
Okay.
you? I wanted to see your face.
Oh, I'm in Berkeley, California.
Oh, wow.
And you can tell you're I'm not on the screen.
No.
No.
We don't see you, Z. Are you at Chez Panisse?
No. But I live. Tell Dennis Shim I live on Oxford Street, 4 blocks from the university.
Nice.
Yeah.
Oh, that's awesome. I miss that area so much.
Yeah. You're a good guy.
When
Good
you're back,
presentation.
if you come back in the city, we have to do an arm wrestling.
And you don't.
Remember we did.
You
the
don't
arm
want to arm wrestle blind guys.
No, I want to arm wrestle you this time with my left hand.
Uh-oh.
I'm stronger. Here we go. Here
it comes, baby. You know, sting like a bee, baby. Sting like a bee.
Oh boy.
All right.
Great presentations, all you guys.
Nice job, everyone.
Yeah.
Wonderful.
Hi, Carlene.
Hi, how are you?
Thank you for the invite.
You're welcome.
Wow, I can't believe that Friday everybody got a couple of hours off. The clinic was closed this afternoon.
Yeah.
It's amazing.
Joe, next time send pictures of the new clinic.
Well, you know, that's what
Coke, yeah.
that's what we were supposed to do. I mean, our meeting last year was going to be in Coke. We wanted to show off the new clinic in person. But again, I think we opened the clinic that first week in March, and the second week in March it was closed.
Yeah.
We're still not there full time. It's only open 3 days a week, but this will get better. Hopefully next year we can all meet in person and we'll get to see the new clinic.
Yeah.
Great presentations.
Yeah.
What a great group of guys.
Yeah.
And girls.
Almost, yeah, just as good as last year's and the year before. And the year before.
No, this is the best I've ever heard. These are professional people. These you guys were lucky.
I hope so. I mean,
yes.
That's well done. I agree.
Yeah.
Well, listen, everybody, stay well.
Yes.
I think we all been vaccinated. I hope everybody else is on their way.
Yeah.
Okay. All right.
Can we
Thank
go?
you, everyone. Be well.
Okay, we can go.
Bye.
Take care, everyone. Thank you.
Bye.
Nice
Bye,
job,
Anna.
guys. Take care.
Go Nets.
Yeah, we'll
Go
see.
Lakers.
Yeah, Nets, baby.
No, LeBron for president. 2034.
Maybe if he's lucky.
That was a great meeting.